postgraduates. So this is a very important topic, urinary tract infections. So if you see the number of the people suffering with the urinary tract infections, it is a very high number in Indian population because of the increased incidence of the diabetes, increased incidence of the infections, and decreased immunity, malnutrition, etc. See, if you see here, so the lot of the clumsiness is there in the urinary tract infections. To understand the urinary tract infections, so you need to know many things to give a very good proper treatment to most of our population. See, this is a very common in the females, so common in the males also. Children's, so common. So recently married, very common. Pregnancy, it's a big problem, urinary tract infections. So left untreated, definitely they will go into the pyelonephritis. And the anatomy of the urinary tract. And these urinary tract infections are divided into the two groups. So upper urinary tract infections and the lower urinary tract infections. See, the upper, that includes the kidneys and the ureters, whereas the lower, three organs here. One is the bladder, urethra, and in the males, prostate. So prostatitis, urethritis, and cystitis comes under your lower urinary tract infections, whereas ureteritis and pyelonephritis comes under upper urinary tract infections. So the most important thing in the children is the vesico-ureteric reflex. So if you see the valves in the bladder, so there will be the defect in the valves, so that there will be the reflex of the urine from the urinary bladder to the kidneys. So that is your vesico-ureter reflex. See, this is the main reason, main cause for your urinary tract infections in the children. So in the same way, urinary tract infections in the children, urinary tract infections in the pregnancy. So one should be treated very effectively, and you need to give the longer duration of your antibiotics to avoid the ascending infections and finally urosepsis. See, this is a very common, the commonest organism is the E. coli. It's from the gastrointestinal tract, but the Proteus, Pseudomonas, Streptococcus, Staphylococcus may also be the causative organisms. You can remember as the KEEP, that is the mnemonic. K stands for your Klebsiella, E stands for your E. coli, and the second E stands for your Enterococcus, and the last P stands for your Proteus and the Pseudomonas. So these are the common organisms to cause the urinary tract infections. So as an outpatient, it's the E. coli is very common, whereas inpatients is Staphylococcus saprophyticus, that is also equally common in our nosocomial or the inpatient hospitalized urinary tract infections. See, the common indication for the hospitalization is the pyelonephritis, and left untreated, so there will be the urosepsis, septic shock, multi-organ failure, and the death. So all the urinary tract infections, you should whistle them. You should identify the urinary tract infections at an early time and act accordingly. Otherwise, there will be a lot of the mortality of this. So the definition is very clear that there is inflammation of the urinary tract, infection of the urinary tract. That what is more important here is the midstream sample of the urine contains 10 to the power of 5 organisms per the ml. So that is the definition of your urinary tract infections. Suppose if you see under the microscope, there will be the 5 WBC for your microscope vision, high power field, and there will be more than that organisms, maybe 8 to 10 or more than that 10 organisms also there for the cubic mm of the urine in the microscope set. So this is the very simple definition, but the treatment is very difficult in controlling the urinary tract infections. It's the second most common infection after your respiratory tract infections. See, there will be some obstruction of the flow of the urine is also there in the urinary tract infections. Maybe anatomical obstructions like your vesico-ureteric reflex, etc. And there may be the functional like presence of the CKD, presence of the diabetes, presence of the immunosuppressive diseases, etc. It's very common in the women because of the short urethra and very proximity to the anal canal. And there will be the antimicrobial tissues will be there, structures will be there in the vaginal fluid. So that may be the absent in the postmenopausal women. That could be another reason for the increased incidence of the urinary tract infections in the postmenopausal women. And as age increases, even the male people also will be having the more urinary tract infections because of the prostatitis. So the prostatic, benign prostatic hypertrophy and infections. So definitely these people also will have the urinary tract infections. So urinary tract infections are there in children, in the young women, postmenopausal women, in the males, and also in the hospitalized population because of the catheter induced or plastic induced. So as I told you that there are a lot of infections here, the keep, that Klebsiella, E. coli, Proteus, Pseudomonas and Enterococcus. So these are very common, and gram-positive, Staphylococcus saprophyticus, that is a very common organism in our inpatients. And sometimes, Mycoplasma, Chlamydia, Neisseria. So these are also involved, mostly the urethritis they cause. So here, the Mycoplasma, Chlamydia, Trachomatis and Neisseria gonorrhea. So they are also common DD for your urethritis. It can be divided as the simple and the complicated. Simple means they don't spread, very localized, very easy to treat, mostly the E. coli. So that can be treated with your simple antibiotics. Whereas complicated, that spreads to the kidneys, and also they will form the perinephric abscesses, sometimes renal carbuncles, sometimes they rupture, they cause the sepsis, and then septic shock and etc. So the lot of the organisms are there in your complicated urinary tract infection. Mostly it is the mixed organisms that cause the complicated UTI. So what are all the causes of the UTI? Normally urine is sterile. Bacteria comes from the other tracts to opening of the urethra. From the gastrointestinal tract, usually most of the bacteria, they enter into the urethra. So there is the obstruction of the flow of the urine, especially the nephrolithiasis. So the renal stones. So that could be the another cause, one of the reasons for your UTIs. And enlargement of the prostate gland, as I told you in the men, a common cause in the elderly individuals. Catheters placed in the urethra and the bladder is a very common nosocomial source of getting the urinary tract infections. Not drinking the enough fluids. So again, especially the working women. So when they travel for the longer durations, they don't eat, they don't drink much fluids. That will be another reason for the more and more urinary tract infections in the females, working women. Waiting too long to urinate. A large uterus in the pregnant woman. So that is the reason in pregnancy we give a lot of importance to the treatment of the urinary tract infections, because as in the pregnancy the uterus will be very big, and that will cause some obstruction in the ureters, some obstruction on the bladder, etc. And the poor toilet habits, wiping back to the front for the women. So from the anal region to the vagina, so that definitely that will lead to a lot of the infections there. The disorders that suppress the immune system, especially the diabetes, is a very, very common disease in our Indian population. And poorly controlled diabetes is an important reason for the urinary tract infections in most of the individuals. So nowadays we are seeing a lot of the oncology cases. They are increasing in numbers. So a lot of the people are on the chemotherapy. So the chemotherapy definitely reduces the immune system of the body. So definitely they are also more prone for the urinary tract infections. So these are the different reasons to cause the urinary tract infections in our individuals. Unfortunately, we have a lot of the defenses, natural defenses, the factors which prevent the infection. Free flow of the urine. So no stasis. When the people passes the urine very frequently, there won't be no stasis. So there will definitely lesser incidence of the urinary tract infections. Acidic urine. So urine is acidic. So acidity kills the bacteria. So that is again another natural defense. And complete the bladder emptying. So that is again the no stasis. So urinary tract epithelium secretes the substances which are antibacterial. So these are the reasons for the natural defenses against our urinary tract infections. But as age increases, or presence of the diabetes or presence of the other diseases, so obviously we lose these defenses, and finally a lot of the people are prone for the urinary tract infections. Any break in this chain can cause the UTI. So in most cases, the bacteria from the gastrointestinal tract, they reach the urethra very easily, especially in the females. They go up as an ascending infections and cause urinary tract infection. So mostly it is an ascending infection. The protective mechanisms for maintaining the sterile urine. The urine is sterile. it is acidic. To maintain that adequate urine value, so you have to drink more fluids every day to get the equal amount of the urine, complete bladder emptying, a normal acidity of the urine, peristaltic activity of the ureters and the competent uretrovesicular junction. So if the junction is disturbed, then obviously the wall will be damaged and there will be the regurgitation of the urine, again leads to a lot of urinary tract infections. Intravesicular pressure preventing the reflexes. In females, antibacterial properties of the vagina. In males, it is the prostatic secretions. See these defense mechanisms in the urine and the mucosal immunity. And if you see the second half, that is mucosal immunity, the urothelial secretions of the cytokines and chemokines. So they protect the mucosa not to have the urinary tract infections. And mucopolysaccharide lining, they increases the difficulty of the bacterial penetration. Mucosal IgA, prostatic secretions contain the bactericidal zinc, and urethra is very longer in the males, so that is the reason they are not having the much urinary tract infections when compared to the females, because of the prostatic secretions. They contain the bactericidal zinc. So these are the mucosal immunity systems. Coming to the urine, the acidic urine, already told you, acidic pH, so intolerable by the pathogens, high urine osmolality, urinary inhibitors of the bacterial adherence, competitive inhibitors of attachment of the uroepithelial cells, and mechanical flushing of the urine flow. Risk factors, the female sex, old age, anatomical abnormality of the urinary tract, obstructive uropathies, maybe the stools, maybe the BPH, etc., and poor perineal hygiene. This is an important reason for our UTIs in the rural India, especially in the poor people. So the hygiene is very, very poor there. So that could be another reason for the urinary tract infections. So you agree with me that we see a lot of the diabetics, especially from the rural diabetics. So the most common infection in them is the urinary tract infection. Not only the simple urethritis and cystitis, most of these people, they present with the pyelonephritis. So the ascending infection. So it's all because of the poor personal hygiene. So pregnancy is an important reason to have more and more urinary tract infections because of the stasis of the urine more in the bladder. And the urethral instrumentation, that is the Foley's catheter. For some reasons, most of the people in the casualty will put the Foley's catheter, whether they needed or not unneeded. So that could be another reason for your ascending infections and immunocompromised populations like HIV, diabetes, etc. So the same thing here, female, uncircumcised male, vascular reflex, toilet training, poor toilet training, voiding dysfunction, obstructive uropathy, urethral instrumentation like your catheters, wiping from back to the front, bubble bath, tight underwears, pinworm infestations, constipation, fimbriated bacteria, anatomic abnormalities, neuropathic bladder. That is again important reason for the more and more urinary tract infections and more sexual activity and pregnancy. The same thing here, the risk factors. Come the risk factors for the catheter associated urinary tract infections. So this is also very, very common. So the prolonged catheterization, mostly the female gender, catheter insertion outside the operation theater. So they don't follow the aseptic measures. So once outside the operation theater. So urology services, more and more urology services, always they keep the catheters. Other active sites of the infections, maybe the skin and subcutaneous infections that could be spread to the UTIs, uncontrolled diabetes, malnutrition. When the creatinine is more than 2 milligrams, that is your CKD. So the CKD population are also more prone for the urinary tract infections because of the low immunity. Ureteric stents, monitoring of the urine output, improper positioning of the drainage tube, and antimicrobial drug therapy. So leads to the drug resistance. So these are the risk factors for your catheter-associated urinary tract infections. What are the MDR UTI? So now the drug-resistant drug-resistant urinary tract infections are very common. So they can be divided into three types of the resistance will be there. One is the multi-drug resistant. The second one is the extended drug resistant. And the third one is pan-drug resistant. So multi-drug resistant means these people will have the resistance to one or two groups of the drugs. So you have the few drugs in your hand to treat the urinary tract infections, like your nitrofurantoin or your trimethoprim and sulfamethoxyl combination, or your quinolines like your ciprofloxacillin, your aminoglycosides like gentamicin or amikacin, and then the azithromycin, phosphomycin, then the ceftriaxone or cefixime or cefipime or cefparazone, that is your cephalosporins. So these are the different antibiotics we often use in the treatment of the urinary tract infections, depending on the site of the infection. Say if the urethritis, we use some drugs. In cystitis, we use some drugs. In pyelonephritis, we choose some drugs. So the MDR means, so there is about 2 or 3 drugs are resistant, that is the MDR. And extended drug resistance, XDR, is the most of the drugs are the resistant, whereas a pan resistant means all the drugs are resistant. See here the risk factors for these resistance are the diabetes is a very important reason. Use of antibiotic prophylaxis for the urinary tract infections, vesicoureteric reflux, nephrolithiasis, renal stones, dysplastic kidney, malignancies, bladder augmentation and other surgeries, anatomical and functional anomalies, gastrointestinal anomalies, hydronephrosis, or inherited disorders of the metabolism. So these are all the reasons for your multi-drug resistant urinary tract infections. See here the length matters. What are the mechanisms of the actions? See the direct contamination. So it's an invasive procedures. So catheter induced, migration, hematogenous, maybe the renal tuberculosis or the staphylococcus. Ascending infections, the very common. Foreign bodies, that is your catheters, etc. Coexisting conditions like diabetes and HIV, etc. Fistulas and Crohn's and ulcerative colitis, diverticulitis. IBS, neurogenic bladder, calculitis, immunosuppression, and non-secretaries of the blood group substances. So these are all the different mechanisms to cause your drug-resistant tuberculosis, urinary tract infection. So as I told you that the classification depends on the anatomical here the upper and the lower. In the upper you have the acute pyelonephritis, the perinephric abscess, or the renal carbuncles, or ureteritis. In the lower you have the urethritis, cystitis, in males prostatitis also. Epidemiological, hospital acquired and community acquired, very easy to treat the community acquired UTIs, whereas the hospital acquired UTIs, they mostly the drug resistant. So you need to use the parenteral drugs, etc. And in the clinical, asymptomatic or the symptomatic. So some people are asymptomatic, even though they have the bacteriuria, they don't have any symptoms. On the other hand, some people, most of the people, they have the symptomatic. What are the common symptoms of the urinary tract infections? One is the increased frequency. Yes, polyuria, dysuria, good, dysuria, pyuria, hematuria, suprapubic pain. So these 6 are the common symptoms of the urinary tract infections. Okay. So polyuria, increased frequency, dysuria, hematuria, pyuria, and suprapubic pain or the lower abdominal pain. So if the pain is in the flanks, when these symptoms are associated with your fever, chills, rigors, or costovertebral tenderness, so definitely it's a case of ascending infections and leading to pyelonephritis. So in pyelonephritis, you will have the symptomatic, systemic symptoms. Whereas in the simple urinary tract infections, lower urinary tract infections, you will have these 6 symptoms only pertaining to the urethra and the bladder. So ascending route already told you from the gastrointestinal, hematogenous route through the blood spread, and the lymphatic route. So these by 3 ways, most of the people will have the urinary tract infections. Here 95% through the ascending route only. So 80% E. coli. So others gram-negative organisms like Proteus, Klebsiella, Enterobacteria, Staphylococcus aureus, etc. Here adenovirus. Sometimes viral UTI and candidiasis. So this is also very common in our population. So the fungus in the urinary tract infections. So candidial, especially in the diabetes or immunocompromised individuals or malnutrition. So again the candidiasis is also important organism to cause a urinary tract infections. So you need not remember these percentages. These percentages differs from the person to the person. So E. coli is the most common anywhere. Proteus 12%, Klebsiella 4%, Pseudomonas. Whereas in India, Pseudomonas is much more common than the Proteus. It's the Western slide. Staphylococcus saprophyticus is more common in the inpatients, especially hospitalized UTIs. Here the Staphylococcus is very common. Candida albicans, a cause of the UTI if the immunity is low. So these are the studies from our Indian authors, Misra, Sharma and Ahmad. So they said that E. coli is very common in all the three groups, and Klebsiella, Pseudomonas, Enterobacter, Citrobacter, Enterococcus, Staphylococcus and Candida. Why I am showing this slide is, see, our people are different from the Western population. See, the organisms causing urinary tract infections in India are different from the other countries. So when you are reading the books of the Western authors, so you may lose the common organisms, so that when you are prescribing the drugs, you may write the non-susceptible antibiotics. Okay, so these are the very important causes for our Indian population. So E. coli, Klebsiella, Pseudomonas much more than the Proteus, and we also have the Staphylococcus aureus. So these are the different organisms E. coli. So the same thing here. So the pathogenesis occurs on the three factors. One is the agent inactivity. So the virulence. So the more the virulent, so the more the disease. Host susceptibility. So when the host is immune suppressed, so obviously more and more infection. And environmental exposure, like your climate, okay, sanitation, social environment, your access to the healthcare, etc. So these three are very important reasons to have the more and more pathology as far as the urinary tract infection is concerned. So the host, agent and environment. So these are the environmental factors like vaginal ecology, so sexual intercourse, use of the nanoxyl 9, which is a toxic to the vaginal microflora. In postmenopausal women, lactobacilli are replaced by the gram-negative bacteria. Anatomical and the functional abnormalities. Females have the short urethra in pregnancy due to the decreased urethral tone and peristalsis. Vesico-ureteric reflux results in. Host factors, the people with recurrent infections will have the mucosal cells with a threefold more affinity towards the uropathogenic bacteria. Polymorphisms, an interleukin 8 receptor gene CXCR1 lead to more susceptibility to the pyelonephritis. Agent factors, E. coli possesses the adjacent fimbriae, which are hair-like protein structures that interact with a specific receptor on the renal. See, this is the fimbriae. Yes. Okay. On the left side, E. coli. See the fecal E. coli in the gastrointestinal tract. So because of this E. coli is having the fimbriae, they stick epithelial cells and atrophic epithelium. So there will be the vaginal introitus, then the diaphragm, sphenoid bladder, stasis, obstruction. So then leads to the pyelonephritis. So conditions affecting the pathogens. So these are the conditions like gender, mostly the females. Pregnancy is a very important reason. Obstruction by any route, maybe to the caliculi or the BPH. Neurogenic bladder and bacterial virulence. So the more the virulence of the bacteria, so the more the chances of having UTI and also ascending infections. So these are the spectrum of the UTI presentations. So asymptomatic bacteriuria. So here the bacteria will be there in the urine, but the patient is asymptomatic. No symptoms at all. Symptomatic cystitis and urethritis. So both are the different. In urethritis, you will have the urethral discharge, whereas in cystitis, no urethral discharge. In cystitis, these people will have some suprapubic pain. In both the urethritis and cystitis, you have all the common symptoms like your pyuria or your dysuria or polyuria, okay, or hematuria, and then the suprapubic pain. Pain will be there in the cystitis, not in the urethritis, most of the conditions. Acute pyelonephritis. Here the fever will be there. Fever, chills and dryness, flank pains. No fever in cystitis or urethritis. No fever in cystitis or urethritis. But fever presence means already ascending infection. Maybe urethritis or pyelonephritis. Acute prostatitis, septicemia. So the gram-negative bacteria. Here septicemia means the advanced case. So the urosepsis. So these people will have the fever and also multi-organ failure, etc. See asymptomatic bacteriuria and the septic shock. So in cystitis, you will have the dysuria, increased frequency, nocturia, suprapubic pain, tenderness, cloudy and very foul urine odor. Fever uncommon. In children, fever is more common in cystitis. Usually in adults, in our practice, in our physician practice, so the fever usually absent in the cystitis and urethritis. Whereas in the pediatrics, children, fever more common even with the cystitis. Typical symptoms and the signs are often absent. See here, very few signs in urinary tract infections. So urinary tract infections diagnosis is 99% is the symptoms only, symptoms. And then your urine examination or your urine culture and sensitivity. Very, very few signs will be here in urinary tract infections. So common symptoms are the signs in elderly individuals with urinary tract infection. See the confusion, drowsy, change in the behavior, not feeling well, weakness, asthenia, anorexia, incontinence. So these are the features of the urinary tract infection in the elderly population. So in elderly population, geriatric population, if you find these persons, that could be a case of UTI also. So how you diagnose? Unless you check the urine examination. So the urine examination is very important. Urine culture and sensitivity is also important in these individuals. Otherwise, you are going to miss the diagnosis. For confusion, for drowsiness, you are thinking of some neurological reasons. Okay, some encephalopathy, etc., or some meningitis, etc. The clinical symptoms upper tract, that means your pyelonephritis, kidney and ureters, the flank pain, fever, chills, nausea, vomiting. Your systemic symptoms will be here in pyelonephritis. In the lower tract, no systemic symptoms. Only localized symptoms and the localized signs like frequency, urgency, dysuria, hematuria, odor, foul odor, cloudy urine, suprapubic pain, sense of incomplete emptying. Constitutional symptoms like malaise, lack of energy, appetite, confusion. So these are all their constitutional symptoms in any acute infections. This is very important. So not all the symptoms here are because of the urinary tract infections. Some people, they have the vulvovaginitis. Here the yeast or the trichomonas. So here when choosing the drugs, so this helps when you have some DD. Here the doxycycline may help you. Okay. Urethritis, chlamydia. Okay, gonococcal. So sexual disorders, sterile pyuria, and postmenopausal ectrophic vaginitis. So these are different differential diagnosis for your urinary tract infections. Vulvovaginitis, urethritis caused by the chlamydia, etc., not by your E. coli or Klebsiella, etc. Okay, and sexually transmitted diseases, sterile pyuria, and postmenopausal ectrophic vaginitis. So same thing here, the symptoms of the urinary tract infections. See the pyelonephritis, you have the two red marks, flank pain and high fever. So the fever and the pains, flank pains, is a very, very common in your pyelonephritis. And WBC and bacteria in the urine, urinary symptoms similar to the cystitis. In cystitis, that is your bladder infection, increased urinary frequency, urgency, dysuria. Again, the WBC and bacteria in the urine is more common in the women. Lower urinary tract infections, DD, chlamydia, Reiter syndrome, urethral syndrome, symptoms and signs of urethritis and cystitis, but no bacteria cultured. So no bacteria culture. Okay, that is your urethral syndrome. The same symptoms. These people will have dysuria, etc., but no bacteria are cultured. That is urethral syndrome. Chlamydia and certain anaerobes need the special culture. Intermittent or low count bacteriuria, reaction to the toileters or disinfectants, symptoms related to the intercourse, postmenopausal ectrophic vaginitis. Now moving to the differential diagnosis of your pyelonephritis. So as a physician, so these are the very important. See, we often see the pyelonephritis only. So for simple cystitis and urethritis, so anyone can treat. But once it is an ascending infection, once it is in a pyelonephritis, once it is a complicated one, once they have the systemic symptoms, so definitely they visit a physician. Here, what are the common DDs for your pyelonephritis? Pyelonephrosis, perinephric abscesses, acute appendicitis, diverticulitis, cholecystitis, salpingitis, or ruptured ovarian cyst or the ectopic pregnancy. So the most of these conditions can be easily detected with your a good ultrasound examination or your CT abdomen. Okay. So before you conclude the diagnosis of the acute pyelonephritis, so you need to rule out these common conditions also. Whenever a patient presents with your flank abdominal pain or severe abdominal pain with the systemic symptoms, so definitely the urine examination is important to rule out your pyelonephritis. And of course, ultrasound abdomen easily clinches rule outs of the most of these conditions. Very simple investigations in urinary tract infections. One is urine analysis under a microscope, urine culture and sensitivity. Not all people require culture and sensitivity. Only in complicated UTI, you advise culture and sensitivity. And imaging when you're suspecting any anatomical obstruction, like your BPH or your nephrolithiasis or etc. You can advise the imaging. So the only investigation which is a very important in urinary tract infection is your urine analysis. Okay. So how many number of the bacteria are there? What about the WBC? What about the nitrite? Okay. So these are very important. What about the pH of the urine? Osmolality of the urine? Or any casts are there? Or any immature is there? So these are very important urine analysis. So within urine analysis, you can identify the most of the cases of the urinary tract infections. And the treatment will be very simple. In some cases, just use azithromycin 1 gram once a day. Or you can use the phosphomycin 3 grams just once a day. Okay, so that is the simplest way of treating the urinary tract infections, provided if you know that this urinary tract infection is the lower urinary tract infection, maybe the urethritis or the cystitis. On the other hand, if the case is a pyelonephritis, then you have to admit the patient, provided if it's a complicated pyelonephritis, and definitely you have to give the intravenous ceftriaxone, etc. for about 7 days to 14 days. And if the patient is also having any abscesses or the carbuncles, so there should be the percutaneous nephrostomy. So the tube drainage must be also there. So these are all the interventions will be required there. So always see that this UTI is a simple UTI. You identify the UTI at an early stage so that the treatment is very easy. So this is the urine analysis. Take a clean, midstream, fresh voided sample. That is a very important. Okay. So the book says that a catheter sample is not possible for all the patients. So to take a catheter sample to detect the urine analysis examination. But a simple, clean, midstream, fresh voided urine sample is sufficient. So in females, there will be the 10 to the power of 5 bacteria per ml of the urine, whereas in the males, 10 to the power of 2 per ml of the urine. So nitrite, that is produced by the bacteria, mostly E. coli. Nitrate will be converted to the nitrite in the presence of the E. coli bacteria. So the presence of the nitrite means already the bacteria is there. Which bacteria is there? E. coli is there. So treat the drugs, antibiotic which kills the E. coli very effectively. WBC more than the 8 to 10 for high power field. Okay, simple 5 for high power field is sufficient to diagnose urinary tract infections. Okay. Leukocyte esterases. So these are the different things. So a midstream urine sample is important, and you see the bacteria is there or not. You see the WBC, you see the nitrates, and you see the pH of the urine, osmolality of the urine. So these are very important things. So from tomorrow onwards, whenever you see the complete urine examination report, you please see these reports. Please pay some more attention to all these things. Except don't think that complete urine examination report is very a simple report. It gives a lot of information, for most of the UTI infections. See, blood present or not. Quick urine test by the dipstick, by the leukocyte esterase and nitrate detected. So now the dipsticks are available most of the times, no? So they see this. Again, tomorrow you see one dipstick. So what are all the parameters they have given there? So whatever the bacteria, nitrates, pH, osmolality, etc. Culture and sensitivity is the most important test, but not in all cases. Not recommended in every case, but it takes a lot of, 48 to 72 hours. Recommended in the diabetics, recurrent UTIs, and in elderly individuals, and failure to respond to the routine treatment. So definitely need urine culture and sensitivity, especially in the females, in the children also, with vesicular reflux, you need the culture and sensitivity. In pregnancy, urinary tract infection pregnancy, again you need the culture and sensitivity. See the indications for the culture and sensitivity. Children, pregnant, elderly, diabetes, immunocompromised individuals, and recurrent UTIs. What you mean by the recurrent UTIs? So the 2 UTIs in the previous 6 months or 3 UTIs in the previous 1 year. So 2 UTIs in 6 months period or the 3 UTIs in 12 months period. It's recurrent UTI. What is a relapse UTI? So the UTI with the same organism. Okay. What is reinfection UTI? So it's a recurrent UTI with a different organism. Okay. So that is the difference between the relapse and reinfection. So the reinfection is the different organism, where the relapse with the same organism. So this is the amazing IV pyelogram, IVP, to know whether the kidney is functioning or not. Culture and sensitivity, CT, with or without contrast, or ultrasound abdomen. So these are the very important. Now they are available in each and every place. So sometimes we get the ultrasound, sometimes we get the CT scan also. Not done routinely, done in the following conditions. In the recurrent UTIs, suspected abnormality in the urinary tract, maybe the stone, BPH, diverticulum, etc. In children and elderly population in the males. Again, in the pregnancy also, we get the ultrasound abdomen, not the CT. In pregnancy UTIs, frequent UTIs in the pregnancy, we get the ultrasound abdomen, KUB. This is the IV pyelogram. Where is the defect? Defect is on the left kidney. See the midstream urine, a colony count, culture and sensitivity, contamination, fungi and chlamydia need the different media. Suspect if the negative culture and the symptomatic. See, all the times the cultures are the negative. The patient is symptomatic, getting the recurrent UTIs. So don't blame the E. coli or the Klebsiella or the Proteus. So think of chlamydia, think of fungal, maybe think of the tuberculosis, etc. So this is a very important. Negative culture, and the patients are mostly symptomatic, frequent symptomatic. So think of different organisms like fungi and the chlamydia. So the diagnosis, the radiological investigations, ultrasound, CT scan, MRI, cystoscopy, urodynamics and uroflow. So that is for your BPH and in the elderly individuals. So these common organisms already I told you. Asymptomatic bacteria, only treated in the infants, pregnant women, and the urinary tract abnormalities. So asymptomatic bacteria, we don't treat it, but we treat in some individuals. When, whom should we treat asymptomatic bacteria? Pregnancy is the very, very important indication. Post-transplant, it is not given in these. Post-transplant, renal transplantation, post-renal transplantation. These people have the asymptomatic bacteria. Again, you have to treat. Pregnancy, you have to treat it. In children with vesicular reflux, again, you have to treat it. Catheter-related bacteria. Asymptomatic patients and remove the catheter as soon as it is not needed. So don't put the catheter for a prolonged period unnecessarily. Persistent of the recurrent UTIs, causative organism persists on the repeat cultures despite the treatment, or if there is reinfection with any organism after an interval, then an underlying cause is the present. In females, if the infections are more than the 3 times in a year, so investigate properly, because it's a recurrent UTI. So investigate with ultrasound, investigate with the CT, investigate with the different culture and sensitivities, etc. So the acute pyelonephritis is the triad of loin pain, fever, and the renal tenderness, always ascending. Rarely bacteremia may give rise to the renal or the perinephric abscesses, mostly staphylococci here. So there you have to use the cephalosporins. Rarely associated with the renal papillary necrosis can lead to acute kidney injury. So this is again important cause for the acute kidney injury is your acute pyelonephritis. So that is the reason all the pyelonephritis should be admitted under your care and then give the parenteral antibiotics and act accordingly. See the urine here. So left one is a clear one when compared to the right one. So right one is very thick, dark colored. So it's mostly of the urethritis on the right side because of the associated urethral discharge. On the left side, mostly the cystitis. So there don't be any urethral discharge on the in the cystitis. So the first one is the cystitis picture and the second one is the urethritis urine because of the presence of the urethral discharge. So dysuria, frequency of the micturition, suprapubic, cloudy, malarial body, no hematuria, no suprapubic pain, urethritis. So the patient doesn't have any local or systemic symptoms, that is asymptomatic. Presence of systemic signs and symptoms such as fever, altered mental status, leukocytosis in the setting of the positive urine culture doesn't merit a diagnosis of the symptomatic UTI unless the potential etiologies are considered. Prostatitis, so these people will have dysuria, frequency, all these things with bladder outlet obstruction. Men with recurrent cystitis should be evaluated for the prostatic focus. So the peer examination is very, very important in elderly males. So the peer examination, you can palpate the prostate. That will be very tender. So that shows it is a prostatitis. Prostatitis or benign prostatic hypertrophy. See the costovertebral angle tenderness is a very common in your pyelonephritis. Catheter associated UTIs are females, prolonged catheterization, faulty catheter care. So this is a very important reason. Most of the catheter care by our sisters. Only we put the catheter. The care being taken by our sisters. So you know how their hands are there, how often they clean their hands, very important. So that is the reason for this catheter associated urinary tract infections. Infection occurs by two routes, intraluminal and periurethral. Most of the infection resolves after the removal of the catheter, preventable by using the sterile collecting systems. So these are all the cystitis, pyelonephritis, treatments, nursing goals, front to the back, etc. These are home remedies for urinary tract infections. So very common all over the world. So vitamin C, so lemon juice will reduce the incidence of your urinary tract infections. Plenty of water and coconut water. So that is also a home remedy. Pineapple, apple, vinegar, and then most important is the cranberries. So they proved that cranberries, so they are they reduces the incidence of the urinary tract infections. So baking soda. So these are all the home remedies for the urinary tract infections. So how to manage the urinary tract infections? Okay. So cystitis. So cystitis, I consider that the cystitis treatment may be the uncomplicated cystitis and the complicated cystitis. Okay. In uncomplicated cystitis, you can use the nitrofurantoin, maybe for the 5 days, 100 milligrams BD for the 5 days. Or you can use the phosphomycin. Whereas in the complicated cystitis, you can use the ciprofloxacin, 500 milligrams, or trimethoprim sulfamethoxazole, 160 plus 800. That is your Bactrim DS. So that also can be used BD. So in the complicated cystitis. So in uncomplicated cystitis, you can use the nitrofurantoin. In complicated cystitis, you can use the ciprofloxacin or Bactrim DS. Prophylactic uroprophylaxis. So you can have the two types of the uroprophylaxis. So you need to remember all these things. So prophylaxis means chemoprophylaxis. Two types. One is continuous chemoprophylaxis and intermittent chemoprophylaxis. Intermittent chemoprophylaxis means so before the sexual intercourse. So then you can give the one tablet of your nitrofurantoin or one tablet of your azithromycin, etc. Whereas the continuous chemoprophylaxis, you can use the nitrofurantoin 100 milligrams OD for about 3 to 12 months. So complicated UTIs, the specific pharmacology, investigate with radiology, refer to appropriate specialty. Mostly you are the right person to treat. You need not refer to the nephrologist or urologist to treat the UTIs. You are the boss to treat the UTIs. Consider low dose prophylaxis while awaiting the referral and the diagnostics, and admit the patient if not responding to the treatment and the fever. This is very, very important. So when the fever is not responding to your routine antibiotics, so that means this is going to be a complicated UTI or going to be an ascending infection or a pyelonephritis. So you need to investigate much further, and then you need to treat with the parenteral antibiotics. So better to admit the patient and act accordingly. So the management, mainly antibiotics, high fluid intake, cranberry juice may be the protective, remove or replace the catheter or the stent if present. Antibiotics are started empirically, then modified according to your culturing reports if needed. So you don't get the culturing reports immediately. So start with the empirical antibiotic. Suppose already told you the cystitis, uncomplicated cystitis, you can treat with the nitrofurantoin, or a complicated cystitis, you can treat with the ciprofloxacin or the Bactrim DS. And then you can send the urine for the culture and sensitivity, and then you can change the antibiotics at a later time according to your culture and sensitivity report. In otherwise healthy females who are not pregnant, so the first choice is your Bactrim DS, and the second choice is your quinolines, that is your ciprofloxacin and fosmicin for your cystitis. In the males, again the ciprofloxacin or the Bactrim, 7 days treatment, not the 3 days. In females, it is the 3 days for the cystitis. Whereas in the males, especially the elderly males, maybe because of your prostatitis, so it's mostly the 7 days treatment. So always in the males, in the elderly individuals, better to use the ciprofloxacin rather than the Bactrim DS, because ciprofloxacin penetrates the prostatic tissue much deeper, much quicker. So that is the reason. So ciprofloxacin is a very good antibiotic to treat the prostatitis. Pregnancy is a very big topic. 6% of the pregnant females have the significant bacteria in the urine. If not treated, can cause the pyelonephritis. See the maternal and the fetal complications. Okay. Routine urine culture and sensitivity is done in the first trimester itself. Even in the asymptomatic bacteriuria in the pregnancy, get the culture and sensitivity and treat them. So treatment is given even if no symptoms at all. So asymptomatic bacteriuria. Treatment of the choice, don't use the quinolines in pregnancy. Don't use the ciprofloxacin or ofloxacin, etc. in pregnancy. In pregnancy, quinolines are contraindicated. So use either nitrofurantoin or the amoxicillin and clavulanic acid. Okay. So that is a good antibiotic. These two are the good antibiotics to treat in pregnancy UTIs, nitrofurantoin or amoxiclav. Urine culture and sensitivity is done before and also the after treatment. Treat for 7 days, not the 3 days like non-pregnant women. In pregnant women, you have to treat with the 7 days. In non-pregnant women, you can use the ciprofloxacin. Whereas the pregnant woman, you should not use the ciprofloxacin. Same here. See the 7 days treatment and 3 days. This is for your cystitis. Non-pregnant females, 3 days. In males, pregnancy, diabetes, and other comorbidities, use for 7 days. Treated only in the pregnancy, or if the patient is going to have any urological surgery, okay, or in children with vesicular-ureteric reflux, or in post-transplant individuals. So these 3 are the 4 of the indications to treat the asymptomatic bacteriuria. So if asymptomatic bacteria is not treated, 25% of the infected women will develop the symptomatic infection during the pregnancy. So chances of getting the ascending infections in pregnancy is about 25%. So almost 1/4 of these individuals will get the ascending infections and pyelonephritis, and very, very difficult. Okay. Even if you want the CT scan, usually you don't get the CT scan in the pregnancy. Okay. So you may lose a lot of the information in these populations. So don't allow the pregnant women with UTIs to go into the phase of acute pyelonephritis. So treat all the urinary tract infection in the pregnancy, whether symptomatic or asymptomatic. Eradication of the bacteriuria with antimicrobial agents prevents the most of these ascending infections. Treatment is a must, not for 3 days, but for 7 days. Bacteriuria responds to the empirical treatment with any of the several antibacterial agents. So usually use nitrofurantoin or amoxicillin. So single dose treatment in non-pregnant women, amoxicillin you can give 3 grams, ampicillin 2 grams, cephalosporins 2 grams, nitrofurantoin 200 milligrams, even azithromycin 1 gram. Okay, or even these are the single dose treatments, or phosphomycin 3 grams. So these are different drugs you can use as a single drug in uncomplicated cystitis in young women. So amoxicillin, ampicillin, cephalosporins like your cefixime, etc., or nitrofurantoin, and then phosphomycin, and then azithromycin. Recurrent UTI. What about the prophylaxis? If a patient gets the recurrent UTI, do the following. Advise increase the fluid intake, frequent urination, investigate for any urinary tract pathology and treat it. So you know the mucosal, defense mechanisms. You know the reasons to cause the urinary tract infection. So act accordingly. So tell all the advices to take the plenty of the water and cranberry juice or a simple lemon juice or coconut water if the patient is not having any hyperkalemia or CKD. Okay, so you advise all these things and then advise increased fluid intake and the frequent urination. So avoid the stasis. So definitely the recurrence of the UTI will be reduced with your advice. And some patients may require long-term prophylactic antibiotics. Then you can use the nitrofurantoin, 100 milligrams OD or the BD for a period of about 3 to 12 months. Okay, so almost 1 year they have to use it because these people are getting the recurrent infections. So 4 attacks, 5 attacks, 6 attacks in a year. So that is the recurrent UTIs. So this is the chemoprophylaxis to avoid the recurrent UTIs. Special situations like chronic indwelling Foley's catheter, WBs and bacteria almost always present there. Treat with antibiotics only if the symptoms are present. Change the Foley's catheter in an aseptic measures. So this already I told you. Acute pyelonephritis, the treatment you can treat with your cephalosporins and also with your IV ciprofloxacin. So these are the very important antibiotics to treat for your acute pyelonephritis. So IV ciprofloxacin 500 milligrams BD or your IV ceftriaxone 1 gram BD or 1 gram TID, or sometimes you can use the meropenem or imipenem also, carbapenem molecules. So depending on the severity, the patient may need oral or the IV antibiotics. Suppose if the patient is not having much fever or not having other systemic features except the simple pyelonephritis without any abscesses or without any carbuncles, the patient not looking sick. So definitely you can treat with as an open OPA based also. Then you can treat with the ciprofloxacin tablets, 500 milligrams BD for about 14 days, not for 5 days or 7 days in pyelonephritis. So 2 weeks antibiotic course has to be given in all the pyelonephritis patients, mostly 14 days. So ciprofloxacin 500 milligrams, or you can use with the cephalosporins. Know the principal goal of the management of the urinary tract infection. Understand that management of UTI depends on the several factors. Know that antibiotics are the main treatment of the UTI. Know the management of the treatment difficult conditions of the UTI like pyelonephritis. It is difficult, and that the antibiotics are the different. Catheter associated UTI is very difficult to treat. Pregnancy is different. Young children is different. Elderly males are the different. So these are the different situations where we have to use the different antibiotics for a different days. Choice of the antibiotic depends on whether the infection is complicated or uncomplicated. Okay. Whether the infection is primary or the recurrent. Type of the patient, pregnant, child, hospitalized, diabetic, etc. Bacterial count. More the bacterial count, so the more the chances of having the sepsis. So presence of the symptoms. Sometimes when the bacterial count is very high, you have to use the 2 antibiotics also. So along with the nitrofurantoin, you can also add the ciprofloxacin. Or along with the nitrofurantoin, you can add the Bactrim DS. So trimethoprim sulfamethoxazole, 160 milligrams plus 800 milligrams. Relapsing caused by the treatment failure. So you advised only 3 days course or the 5 days course in a complicated UTI. So what will happen? Again, the relapse will be there. Okay. So the duration of the treatment is also very important. And if you didn't find the structural abnormalities, so again, the infection, the stasis of the urine will be there, and again, more and more infections. And abscesses. So there should be any, no abscess should be there. If any abscesses are there, there should be drainage of the abscesses there. So we have to take the advice of our urologists. So to go for your stents. The antibiotics used at the initial infections treatment is for 7 to 14 days. So mostly the 14 days for your pyelonephritis or relapsing infections. So same recurring infections I told you. Antibiotics taken as soon as the symptoms develop in recurrent infections. Clean catch urine test should be taken for the culture. Postcoital antibiotics. So the recurrent UTI is related to the sexual activity, and episodes recur more than the 2 times within the 6 months. A single preventive dose taken immediately after the intercourse. And again, after the intercourse, the urine widings are very important things, and plenty of the fluid intake. So then here the antibiotic, single dose of the antibiotic, like your Bactrim DS, or cefalexin, or ciprofloxacin, or azithromycin, okay, or the phosphomycin. So these are the very important antibiotic single dose courses for this postcoital antibiotics. Prophylactic antibiotics, they reduce the recurrence by up to 95%. So that is the reason I told you the chemoprophylaxis, intermittent chemoprophylaxis, and the continuous chemoprophylaxis. Uncomplicated pyelonephritis, it can be treated at home with your oral antibiotics for 14 days with either cephalosporins or amoxicillin or ciprofloxacin or Bactrim. These 4 are the important antibiotics to be used in the pyelonephritis: ciprofloxacin or Bactrim DS or your amoxicillin and cephalosporins as an outpatient. But as inpatient, again the same one only. Here inpatients we use more of the ciprofloxacin and cephalosporins. Urine culture is very, very important. See the bottle, that is sterile bottle. Moderate to the severe pyelonephritis, patient need hospitalization, IV route, imaging tests are very important. So this is a chronic pyelonephritis. So left untreated acute pyelonephritis or partially treated. So these people will end up with the chronic pyelonephritis, and finally it is again a common risk factor to cause CKD, chronic kidney disease. Okay. Chronic glomerulonephritis, chronic pyelonephritis, these 2 are the risk factors for CKD, chronic kidney diseases. Treatment of the specific population, pregnant women, high risk for UTI and complications, should be screened for UTI even on the first antenatal visit. Antibiotics during the pregnancy includes amoxicillin, ampicillin, cephalosporins, nitrofurantoin. They should not give quinolanes. Pregnant women with asymptomatic bacteriuria have 30% risk of acute pyelonephritis in the 2nd or the 3rd trimester. So in the 2nd trimester, 3rd trimester, treating the pyelonephritis is very, very difficult with high grade antibiotics and hospitalization. That is the reason even in the first antenatal visit itself, in the first trimester itself, whenever the fellow is having asymptomatic bacteriuria, treat accordingly, not to have the pyelonephritis at the later time. Screening and 3 to 5 days antibiotics is needed. Uncompleted UTI needs 7 to 10 days antibiotic treatment. Whereas non-pregnant, we use only 3 to 5 days. Pregnancy, we use 7 to 10 days. Diabetics, you all know that they have more frequent and severe UTIs, treated for 7 to 14 days with antibiotics, even patients with uncompleted infections. Because diabetes itself will increase the chances of having the shock, sepsis. Urethritis in the men, here the doxycycline will help. Whether you are in a doubt whether the patient is also having the chlamydia or Neisseria gonococcus, etc. So here the doxycycline will help. Require 7 days regimen of the doxycycline. A single dose of azithromycin may be effective, but not recommended to avoid the spread to the prostate gland. Patient should also be tested for the accompanying sexually transmitted diseases. Children usually treated with the Bactrim or the cephalosporin, sometimes given as IV. Gentamicin may be recommended as the resistance to the sulflexin is increasing, but again the gentamicin will have a lot of the side effects. Vesicular reflex. This is for the pediatric uses. See the reflex on the left kidney. Catheter induces are very common. Preventive measures are important. Catheter should not be used unless absolutely necessary, and they should be removed as soon as possible. That is the best take-home message. Most of the times in our emergency rooms, we use catheters unnecessarily. See, catheter should not be used unless absolutely necessary, and they should be removed as soon as possible. Intermittent use of the catheters. If catheter is required for the long periods, it's best to use intermittently. Don't keep the catheter for days or the months together. It may be replaced every 2 weeks to reduce the risk of the infection, and irrigating the bladder with antibiotics between the replacements. Daily hygiene and use of the closed system to prevent the infections. Antibiotic therapy has little benefit if the catheter is to remain in place for a longer period. Okay, so whatever the antibiotics you use it, they are going to be resistant. So drug resistant will be there with your prolonged usage of your catheter antibiotics. If stones are strongly suspected, the renal examination, that your ultrasound examination, plain abdominal X-ray will identify nearly 90%. MRI may disclose the cause of the persistent infections. Cystoscopic placement of a double J ureter stent. This is a very common stents. We use it in the urologist hands. Percutaneous nephrostomy. Surgical removal of the stones may be required in some women. See the stone in the ureter, in the mid ureter. There is one stone here. See the percutaneous nephrostomy tube. See the stones are removed. So the frequency infection, nitrofurantoin, at bedtime, given for the remainder of the pregnancy, reduces the bacteria recurrence. So these are all the treatment of the UTIs. Conservative versus the radical treatment. All the antibiotics already told you. So something about these drugs. Your Bactrim or the Septron. So alone each agent is bacteriostatic. Together they are bactericidal. So synergism. So tribethoprim and sulfamethoxazole. So individually they are bacteriostatic. So as synergetically they are bactericidal. Optimal ratio of the trimethoprim to sulfamethoxazole is 1:20. So these are pharmacokinetics, sulfonamides, mostly peroral, rapidly absorbed from the stomach and the small intestines, widely distributed to the tissues and body fluids, including the CNS and CS, placenta and the fetus. So that is the reason it's very commonly used in the pregnancy and in the children. Metabolized in the liver by the process of acetylation, eliminated in the urine. Again, this is also orally, well absorbed, widely distributed in the body fluids and the tissues, more lipid soluble, protein bound. These are the important adverse effects. So that is nausea and vomiting is very common with your sulfamethoxazole pyrimethamine combination. Some people are allergic, hematologic, acute hemolytic anemia, megaloblastic anemia due to trimethoprim. So these are the common adverse effects. Nausea, vomiting, allergy is a very common. Some people will have the acute hemolytic anemias or the megaloblastic anemias. Drug interactions. They displace the bilirubin if severe, kernicterus, potentiates the warfarin, varosulfonylurea, hypoglycemia. So contraindications, pregnancy, lactation, infants, renal failure and the hepatic failure. So for us, it is the renal and hepatic failures as a physician, okay, and pregnancy. So these are very important contraindications to use this, your Bactrim DS. Blood disorders, because acute hemolytic anemias and megaloblastic anemias. Nitrofurantoin, very, very useful drug, widely used in the management of your urinary tract infections. It is a bactericidal for both gram positive and the gram negative bacteria, effective against the E. coli, and Staphylococcus saprophyticus. So E. coli is very common as the outpatient or the inpatient, as outside the or the inside the hospital. Staph, very common in hospital UTIs, not that common in outside. But other common urinary tract gram-negative bacteria may also be resistant to the nitrofurantoin. Sensitive bacteria reduce the drug to an active agent that inhibits the various enzymes and damages the DNA. So this absorption is complete after the oral dose. Metabolized and excreted rapidly. No systemic antibacterial action is achieved. Concentrate in the urine. pH, keep the pH less than the 5.5. So that is acidic to enhance the drug activity. So we need the acidic urine, and this nitrofurantoin will keep the urine acidic. It turns urine to a dark orange brown. That is harmless, even though they takes. GI disturbances, bleeding of the stomach, nausea, vomiting, diarrhea must be taken with the food. But most of the people, they tolerate very well to the nitrofurantoin. Very rarely we see these side effects of the nitrofurantoin. Headache and nystagmus. Hemolysis in patients with G6PD deficiency. Contraindications, patients with the G6PD deficiency leads to anemia, neonates, and pregnant women after 38 weeks of the pregnancy. So the doxy, so thanks to Ella Pragat Subbarao garu, it's a long-acting tetracycline, bacteriostatic, inhibits the protein synthesis. So usually given orally, absorption is 100%, distributed well. It crosses the placenta and excreted in the milk, largely metabolized in the liver. Side effects, gut, thrombophlebitis if you give the IV doxycycline. Hepatic toxicity, prolonged therapy with high dose. Brown discoloration of the teeth, children. Deformity or the growth inhibition of the bones. Phototoxicity, vertigo, superinfections. So contraindications here, doxy, pregnancy, breastfeeding, and children. So you can use 100 milligrams. Fluoroquinoline, ciprofloxacin, super drug, excellent drug. Active against gram-negative aerobic organisms. So DNA gyrase enzyme, multi-drug resistant organisms, Pseudomonas. Adverse effects, gut, CNS, damage of the growing cartilage, reversible arthropathy. Some people will have the arthralgias with the quinolines. So aminoglycosides like gentamicin and amikacin, very useful drugs against gram-negative. They cross the placenta. Adverse effects, ototoxicity, nephrotoxicity. Vestibular nerve damage, neuromuscular blocking effect. Cephalosporins, very, very useful drugs, very safe drugs, both the ceftriaxone and ceftazidime, mainly effective against the gram-negative bacteria, acts by inhibition of the cell wall synthesis. It's a bactericidal, mostly parenteral. These are the common scenarios, young females, etc. Pregnancy, so old males, neurogenic bladders. So renal tuberculosis. So hematogenous route, secondary infection, starts in the cortex, in the kidneys, sterile pyuria, cystoscopy for the bladder involvement, chest X-ray and imaging of the urinary tracts are mandatory, treatment by anti-tuberculous chemotherapy, surgery in case of obstruction, if any obstruction is there. So it's very not that common, renal tuberculosis, but in India, in a country like India, so there is all possibility of the renal tuberculosis there whenever you say case of sterile pyuria. So sterile pyuria, one of the DDs is your renal tuberculosis. So here, genitourinary tuberculosis, major criteria, granulomatous lesion in the biopsy specimen, AFB in the urine or the tissue. So send the urine or your renal tissue for your AFB, positive PCR section. These are the causes of your sterile pyuria, contamination of the poorly collected urine specimens, analgesic nephropathy, Staghorn calculi, polycystic kidneys, tumors in the bladder, COX, appendicitis. So these are the causes of sterile pyuria. So you can, in such situations, so you can think of something else, not your E. coli or your Klebsiella or Proteus. So it is divided into two groups, sterile pyuria, infectious causes and non-infectious causes. In the infectious causes, current antibiotics, recently treated gynecological infections, urethritis due to chlamydia, mycoplasma, ureaplasma, prostatitis, balanitis, viral infection of the lower urinary tract, fungal infections, parasitic infections like trichomoniasis and schistosomiosis. So these are all the reasons for your sterile pyuria as far as the infections are concerned. Non-infectious causes, they are also equally important. So they are presence or recent use of the urinary catheter, recent cystoscopy or urologic endoscopy, urinary caliculi, foreign body like a forgotten stent, urinary fistula, polycystic kidneys, resection in a transplant kidney, renal vein thrombosis, interstitial nephritis, interstitial cystitis, papillary necrosis, lupus or Kawasaki disease. So they are the non-infectious causes of the sterile pyuria. So sterile pyuria is a very common. It has two reasons. One is infectious causes, like a lot of the things, and non-infectious causes like lupus or interstitial nephritis or transplant kidney resection, polycystic kidneys, or forgotten stents, or catheter induced. So these are the different reasons. Okay. So children UTI, that is also very common. E. coli resistance, that is going up in India. E. coli is the most common organism, but unfortunately resistance. They carry multi-drug resistant plasmids. Marked increase in the E. coli resistance is occurring over the last decade to various antibiotics including penicillin, cephalosporins, trimethoprim, sulfamethoxazole. Treatment is usually based on local resistance rates and the pattern. So use the drugs very effectively. Don't use for them 10 days or 15 days or 20 days. When they require for 1 day or 2 days or 3 days, just use them only. So prolonged usage definitely leads to lot of the resistance. So this is the microabscesses and pus cell casts in a nephrectomy specimen from the emphysematous pyelonephritis. See, sometimes nephrectomy is also needed. Total kidney is lost. So if you see the IVP, no dye is entered into the opposite kidney. So there is non-functioning kidney. So the only we have to sacrifice that kidney just because of your ascending infection, just because of your acute pyelonephritis or chronic pyelonephritis. So that specimen is sent for the HPA, histopathological examination. Here that shows the pus cells, casts, etc. See again here, emphysematous polycystitis, total bulla, gas bulla here, CT scan. So this is for your pregnancy. Antibiotic resistance. So as a postgraduate, you should know why the resistance. Resistance because of class A serine based B lactamases, carbapenemase KPC, class B carbamases, that is MBL, amber class 3, then OXA, oxo enzyme they have. So these are the enzyme classes. They cause the resistance. See the uncompleted UTI drugs. Risk factor for your candidiasis, fungal infections. So the renal, the risk factors are neutropenia, recent surgery, and central venous catheters. For lower urinary tract, catheter, AS, female, diabetes, obstruction, antibiotics, or instrumentation are the reasons for your candidiasis in the lower urinary tract. Upper urinary tract, again AS, that means mostly elderly, more poorly uncontrolled diabetes, more antibiotics or antibiotic resistance, or anatomical obstructions, or urinary tract instrumentations so lead to upper urinary tract candidiasis. So these are the how to treat the candidal infections with your amphotericin B. Here the fungal granuloma after the nephrectomy. So again the kidney has to be sacrificed for your fungal infections. Here see the fungus ball. So fungal granuloma in a nephrectomy specimen. Here the aspergillus. So strategies to prevent the UTI. So simple measures: increase the fluid intake. Avoid before and after the intercourse. This is very, very important to avoid the UTIs. Personal hygiene. Avoid the feminine hygiene sprays. Take showers instead of the baths. Cranberries, some juices, vitamin C, apple juice, etc., or coconut water. Assess the voiding pattern. So these are all the strategies to prevent the UTIs. In summary, a commonest bacteria is the E. coli, more common in the females. Usually for 3 days in uncomplicated. In complicated, you can go for the 5 to 7 days or 7 to 14 days or maybe beyond the 14 days also. For in males and the pregnancy and the children, you have to go for the 7 days treatment. In pregnancy, if bacteria are present in the urine, treat it even if it is asymptomatic. Otherwise, 25 to 30% they go into the pyelonephritis in the second trimester, third trimester. Obstruction in the urinary tract, increase the risk of the UTIs. So anatomical obstructions. So take the help of the urologist. Antibiotics used in non-pregnant female, Bactrim, ciprofloxacin, amoxicillin or nitrofurantoin. In the males, the ciprofloxacin and the Bactrim, that is your sulfamethoxazole pyrimethamine combination. In pregnancy, nitrofurantoin or amoxicillin. Don't use the phenolines in the pregnancy. So I think this is a very important. So love your parents and treat them with the loving care. You will always know their value when you see their empty chair. Okay. Thank you very much for your patient hearing.